Nice. Terry, did you want to kick off with anything? Any overriding comments?
I think the one thing I just wanted to say to the group here is what Chris is going to be showing you is the new hospital transport status dashboard that actually monitors in near real time using your CAD data, not only units that are transporting to the hospital, but also the amount of units that are at the hospital and how long they've been there. But I think, and I don't want to take away from what Chris is going to show you, but one of the key features now in the newer dashboard is the ability to see what's been going on at the hospital. So you're not seeing what is just happening right now, but you can see how overloaded they were prior to your unit transporting. So I think that's the biggest portion of it. And then if there's any interest from anybody that wants to see this, please reach out to your regional manager in your territory, and we can give you that information at the end as well.
All right, thanks, Terry. My intent today, just take a few minutes and kind of demonstrate how, as the conversation that we've just been through has evidence, this whole concept of system status and ambulance utilization has evolved from what was primarily what's going on with my system to very complex requirements for overall patient flow management, bed management. Some larger systems now have requirements for areas of excellent specialties of care, multiple campuses. And so we've really expanded and are currently expanding the functionalities of what was originally just kind of a hospital transport status dashboard. So I want to just take a couple minutes, run you through maybe the evolution of this and give you a couple of examples of kind of where we are and where we're going. So with any luck, I will be able to share a screen. All right. Can you guys see a screen now?
Yes.
And hopefully it's the right screen that shows a conventional hospital transport status dashboard.
It does show that.
Okay, awesome. Thank you. So this is pretty much where it started. As you can see, this is a demo. But originally what we set out to do, as Terry described, is just say, okay, what's the current status of my system? For all of the facilities in my system, how many units are en route? How many are currently arrived? What's the average time from door arrival to transfer of care? And then what's the max time of those units that are either en route or arrived at the hospital? These are conditionally formatted. So based on whatever the county, LEMSA, regulatory authority or hospital wanted to see, red is bad, yellow is caution, and green is within standard. And so it's pretty much just a kind of a basic functionality. Now, there were some things that were added to it. We've added a transfer of care functionality that is built into the product. So literally taking the paramedic provider's mobile device, you touch a screen, the accepting nurse touches the screen, and then we've got a legitimate, verifiable transfer of care time as part of the data. There's various modalities that we can use to get there. Some of them is signature capture. Some of it, as I said, is just a direct MODAT data input. We added another functionality here to hide zero transport. So if there's no activity currently, it gets rid of all of the white noise on the board. And then for each facility, there is a drill down of a detail of what is going on for the calls that are listed. And so in here, this basically at one click takes you to the existing CAD data. And obviously this is all de-identified, but a system administrator, charge nurse, whatever the case may be, has the ability to get some additional information of everything that's going on relative to that call at that moment in time. So this was kind of the basic start point of this. As we got in, as we said, there's a desire and need to become more granular as well as expand several of the options. So we started expanding the amount of data that is provided in here. This is an example from San Diego County. So you can see the left-hand side is identical to where we started. And then we're starting to do filtering by time, greater than 60 minutes, greater than 90 minutes, greater than 120. And we're adding historical data, right? So not only how are we doing at this moment in time in terms of a snapshot, but overall for the last 3 or 4 hours, how are my facilities doing? Is there a trend developing as it relates to the activities and the offload times? that are involved. We also then have the same ability to drill down to the very specific CAD data related to those particular calls. We then had our customers come back to us and said, so we actually, that's really cool, but we need to have some more views into the same data. In other words, there's a lot of different functions that we want to make sure that we're capturing. First and foremost, we want to make sure that you continue with the historical data because we really want to see the trend of what's going on in our facilities. We'd like to understand, is this a abnormal volume that we're looking at? So we've gone and included historical data, maximum demand times by hour of day for the set 24-hour period, and where we are currently in terms of what's going on. You can select whatever hospitals that you want, and it will take you to the data related to that specific hospital. This is all color-coded, and again, it's the same data en route arrived, the average turn time and the maximum turn time, and then the historical view of the last 3 hours. The same functionality exists. Part of the design goal in this is to just make it a little more contemporary, a little more white space, easier to read, but basically has the same functionalities other than the ability to look at individual hospital systems and generate the information down below. The big change is we've also then created a bunch of different views based on the user. So, for example, one of the requirements that have evolved in our systems is some systems want to maintain the security and secrecy, if you will, of each facility's activities and what's going on. So facilities didn't really want to share information, so we created a functionality where this is essentially kind of a post and look view. It is defined by the login of each facility. Each facility has their own view, so it is basically just an activity view of that facility. So again, conditional formatting, if you're above the standard, it starts flashing red. You can see at this particular facility, they've had 4 or more units there for 60 minutes or longer. That's why you've got such a preponderance of red. Yellow, again, 30 to 59 minutes. And you can see that, pretty busy right there. We also then have the ability to look down here and say, historically, this is just a demand chart. Red is long delays. Green is, short, relatively short time. So it kind of just gives you a quick view of, how can I expect my activities to be? And again, the overall arrivals by hour and the maximum demand over the past 18 months or year, depending upon what the customer wants to create. If the system has provider ability to do destination determination, we've created a crew view, again, based on logins. It'll provide the centers of excellence and the 5 or 10 top facilities that unit by login would be expected to go to, so they can just take a look and see, ooh, where's the red? Do I want to go there? Obviously, in some systems that don't have the discretion of transport determination, not really relevant, but some systems do have the option. And we've created a supervisor view, which basically provides alerting within this for supervisors in the field to say, oh, okay, so what's going on? Why do I have this unit there that's been 1 hour and 23 minutes? And do whatever is appropriate in that system for supervisors to do. A couple of additional functions that we've come up with, and hopefully this will work as well. Are you guys seeing a static display up here? CCEMS hospital dashboard?
Yes.
Yes.
Awesome. So this is just another example of some of the things we're doing as it's evolving. In this particular case, we're including overall ED volume, in other words, bed capacity, how many ambulances arrived, what's their current walk-in volume. We're doing integrations with companies like ReadyNet in California and others that can provide this data, and this is kind of evolving into kind of a bed management overall ED flow issue. Again, same capabilities exist there. There's been some discussion in the previous hour about assigning costs to and tracking costs of wall time. So this is a report that we've created for one of our customers that basically takes their unit hour costs, puts parameters around the agreed to wall time, identifies the 90th percentile, and then assigns a cost based on the amount of wall time in excess of the acceptable standard. that this particular agency has generated. And this is just in January of 2023. So kind of a fascinating number. So this was just an example as I was attempting to talk that included total ED volume, which is the ambulance volume arrived at scene, as well as the current walk-in volume. As I said, we're doing integrations with ReadyNet and other folks that are able to generate this particular data and just give the system an overall view of by facility, what's going on in terms of bed availability, and are they ambulance arrivals or walk-in, and what's going on, and obviously impact as it relates to 60-minute offload times.
And Jonathan does have a question here.
Hi, Jonathan.
Hey, Chris. Good to see your face, man. It's been a long time. Too long. Yeah, just a quick one actually, because the reference to ReadyNet sparked an interesting question here, I think, to me anyway, which is the issue of timing. Someone earlier had mentioned other systems like EM-Track or EM-Resource, something like that. How are you guys aligning, or are you aligning with the ping frequency on those systems? Since obviously if you're generating data from ambulance at one frequency and they're updating it, for example, twice a day, the numbers can fall out of sync. Or how are you guys partnering or tailoring, or are they tailoring to you?
We are still in the process of negotiating exactly what that's going to look like and at what level, but clearly it's one of the requirement issues that we've been working on, in the overall product design. So I don't have a definitive answer for you on that, Jonathan. Sorry. So this is an example. I think Kevin had brought up an issue of some folks generating the overall costs associated with it. So this is a report that we do for one or more of our customers that identifies what are the acceptable and agreed upon limits for wall time, identifies unit hour costs associated with the various units and delivery types, and then assigns a cost based on those hours that are spent in excess of the agreed upon APOT time.
And Steve has got his hand raised as well, Chris, if you're up for it.
Steve.
Yeah, I was just wondering, with the metrics that you guys can add in, and it's not really your problem, it boils down to discipline. I wish I could say every employee was a great employee, but with where during COVID, with the 5-hour wait times, we're now discovering that our units may be taking a nap in the middle of the night for 2 hours, which obviously is not your problem. But is there a way of the system being updated? Because I know we have FirstWatch, but it scrapes off of our CAD data, which is relied on our providers. Is there a way of, when the hospital actually gives our providers a bed, that that this information is updated on the hospital end, so that we can see, hey, that unit's been at the hospital for 3 hours, but they got a bed 2 hours ago, so that we can handle what we need to without having 3 supervisors driving back and forth between 8 hospitals all night long?
Yes, we do have what we call transfer of care, or TOC functionality. So the purpose of that really is to address what I think you're talking about right now, which is, how do I make sure, and how do we, retrospectively evaluate that, yeah, that transfer occurred, and yeah, the crew decided to, take a lunch break or do whatever, they were going to do. So as I was mentioning before, there's a couple of different ways to get there. One is just, integrating transfer of care into the record system, the device that the paramedics have. Another is capturing the time of signature capture in some systems that obviously would require at that point a EPCR or RMS data connection to do. So like everything else in EMS, if you've seen one system, you've seen one system. So it just really depends on the method of doing it, but it is a functionality that is sometimes incorporated into the HTSD that we have here.
Chris, just to add in a tale from Richmond, we did exactly what you described, but also integrating all the systems. The measurement times are patient handover to then you can actually then track that back to crew showing clear, then actual wheels moving off the AVL, and so you can then work out if you have you know, and we have to admit, right, these things do happen. The point that you hand the patient over, then you'll either go to the break room, or you need to take a breather, or you need to complete an EPCR, et cetera, et cetera. But the key thing is to understand who and how and when that's occurring. And so taking it all the way back to when did the truck actually move was something that we were able to measure. And then, you know, it's then helps hospitals, who of course may well kick back and say, actually, yeah, we signed you off here, but you didn't leave for an hour, as somebody just mentioned. So again, this is one of those data points that we need to be absolutely clear on when we're talking about legislation, when we're talking about discussion, when we're talking about fines. The fact is that when did the crew physically leave? And that's something that we have to have the systems to be able to understand, to demonstrate. Over.
Yeah. Yeah, and so just kind of moving along on the theme of different things that we're doing here. This is a variation on some of the things we're doing with the new hospital transport status dashboard. You can see we have all the summaries over here, but in this particular system, there was a interest and a concern about, so what patients am I getting because I'm a center of excellence? And what are we doing in terms of just distribution, right? So it lists like, so how many patients have been transported there and for what reason, right? Burn center, STEMI, whatever the case may be, and an overall view of my system, right? How many units do I have staffed at that particular moment, and how many are committed? So this is literally a level 0 or level 1 system at the moment. And then gives you the ability to look and see exactly, you know, what is my overall elapsed time? What is the impact that this is having on my elapsed times down here? Same type of thing. This is designed for a dispatch center. Same kind of thing where their dispatch and hospital destination is determined on a rotation basis. It creates a logic and brings this up. And again, quick view of how's my system doing and where are the patients and how are things going. It also provides a degree of credibility. If you have battling systems that go, oh, you know, they always get it because they're the base station or whatever, you have the ability then to go, well, no, it actually looks pretty even at this point, or not if it's a problem. And then the last thing I just want to share with you is some of the things that we're doing on a large system basis. Gives you a report. Basically, you can do it by medical center, by facility. You can do it, again, APOT as referred to earlier, gives you an overall view temporally over time. How are we doing? Is it getting better or getting worse as it relates to total transports? And then some graphical representations of that for either public disclosure or system leadership review of, you know, what's going on in terms of the data on a temporal basis. So that's kind of where it's been, kind of where we're going. Those are kind of our thoughts. We have a couple of other really exciting projects going with some very large health systems that have multiple campuses. That's going to get into potentially, anyway, a product that deals with patient flow, bed management, direct admits, coordination of specialty centers within their multi-campus system, and some other things. So it's basically working with hospitals and facilities to design an overall patient flow and bed management coordinating software. So we're working on that, and yeah, it's going to be a ways down the road, but I think it just points to, I think one of the bottom lines that came out of this call is that this is obviously a dynamic and evolving situation. The needs are changing, the looks need to be more granular. And as indicated before, this isn't just an EMS issue or a hospital issue. It really is a systems issue, and our ability to help you with the data from a systems view, I think is critical to your success as well as ours, and that's what the focus is on. So that's all I got at the moment, Terry or Mike or whoever.
What questions, comments, quips, quotes does anybody have around any of this?
I think one of the questions, Chris, that came across to me privately was, the question is, do we use EM systems, or can we interface with EM systems into our dashboard?
Yes. Essentially, basically any database, right? It used to have to be a relational database, but basically if it can be put into a database of any kind, we can figure out a way to make it work.
It's the only ones that came across to me anyway.
I do have a question for you. Where is the largest example that you have of this rolled out in a county or a state? Who would that be? Where would that be?
Probably the largest, I would guess. Terry can help me with this, but it'd be LA County, I would think.
Okay. You know, one thing that comes to mind with this system, and you know, I've not had any first-man experience with it, but you know, a couple of times over the years, I've gone to the Duke Endowment when I was in my official role, and they got more money than they can count. And the thought of sort of discussing a system like this with the state Office of EMS, which I'm on the board, and then seeing which hospitals in the state might be interested in. And we could do that through the Hospital Association, where I've been chairman. So I think we could do that. Get the institution of medicine involved, and I've been chair of that. So all these are places we know pretty well, and ask the question, could we have a statewide system with grants from Duke Endowment or Kate B. Reynolds or those things to cover an entire state with a system and introduce it? So that's something I'd like to explore. And I hope that makes you anxious, but it is something I think we could try.
And Bill, just to further your question too, a couple of the other bigger systems or just systems period is National Capital Region is on this new hospital dashboard.
Okay.
The other one is Las Vegas and Clark County was probably one of our very first hospital dashboard customers for the whole state. So
Yeah.
where we had the Nevada State actually back that one up. And that was when we created the dashboard to start with. And that was our start into this arena, into looking at the transport times and such.
Yeah, well, I think this is really important, and I would say to you, outside just the general you're presenting it, I'd love to figure out how I could take this up and discuss it at the Hospital Association and discuss it at the state EMS, and just see if we could look at a rollout of something like this across North Carolina.
What we did in the early years on the California side too, when we were starting to break into Southern California, is we actually created a PowerPoint for them, and we had nurses, ER nurses. I want to say chart. I can't remember their exact level of their seniority inside the hospitals, but they actually helped us to introduce us to the facilities themselves to show it. I think Kaiser was one of the big ones in Southern California that helped us to really introduce how this could help them to know what was going on inside their facilities. They did get the CEOs, like you mentioned earlier, the CEOs did get involved in it. And a couple of things that Dr. Mackey said rang true as well, that we were dealing with at the same time with the transport coordinators and that sort of thing. So you guys all hit a lot of really important targets that we're trying to join in with you on.
Well, let's follow up on this conversation, Bill, because it makes sense if we can provide some help, and there's a foundation that might be willing to help fund it, and we can be part of helping make things better for both the hospitals and the EMS systems together. We'd love to participate in that.
Yeah, and it would be interesting to talk to the American Hospital Association about this and make them available. And, we could probably get an appointment there. And I just say, because it is a national problem. And if we could get a or somebody behind it, I think they're as interested as fixing things for hospitals as we are for fixing things for EMS. And no hospital wants somebody waiting around like that. I mean, you feel like they're neglecting it, but that's the people that send the letters to the Medicare and Medicaid and all those things. And you have to report that time on your performance. And it's not good when you have these delays. It is a cost to the hospitals, it very much like you all, with a cost you don't see and we'll never see, but it's out there. And the illegal exposures and all the things that should be done because it's just our duty to take care of patients. But if it can't be done, honestly, sometimes you have to describe the situation and ask for help, including funding. And there's just a lot of big grant groups in the country that look at how do you improve something across an entire state and might very well fund it.
Perfect.
Could well be a California
let's follow up
solution.
on that.
Okay.
This could well be a California solution as well, Mike, in the same way that under RFP, all ambulance providers have to have the OCU. And for those that I'm sure everyone's familiar with that on this call, but that's measuring our response time compliance and therefore potential fines that accompany it. It wouldn't be much of a leap to add this particular system into the RFP to actually enable it, certainly from the ambulance data perspective, to be included as well. And that may well answer some of the we need more data discussions that are
Absolutely.
inevitably about to come out during the APOT hearing legislative process that we're about to enter into.
That sounds great. Well, this brings us to the bottom of the hour, right on time. Rob, with the last word again, we appreciate it. If anybody else has any questions, I'm happy to stay on for a little bit. But Chris, thank you very much for walking us through this, and Terry for your help and support, and Bill and Rob. It is always fun seeing you, and Kevin. Thanks again for joining us for everything, and all the rest of you for showing up. It's no fun to hold a party if nobody shows up and eats your snacks and drinks your beer. So we're grateful to all of you for participating.
Thank you, Mike.
Party like a Takeman party.
Yeah. Yeah. Thank you very much.
Thanks, everybody. Thank you.
Absolutely.